let's make a massive round of applause to start for Dr. Janet Settle and Dr. Will Van Derveer.
Thank you. Thank you, James.
Thank you, James. Thank you so much to Functional Forum for this invitation. We're so excited about the future of psychiatry and about integrative psychiatry. But honestly, we didn't start out excited about psychiatry, did we?
No, we didn't. So I finished my residency in the early 2000s, and it took me a couple of years to quickly realize that the tools that I had learned didn't work all that well. I had a lot of people in my practice who were falling into the category of treatment resistant. There were people who had ongoing symptoms, people who didn't respond to medications, people who had a lot of side effects to medications. And what ended up happening was I got really frustrated and decided that it was time for me to go and find some better tools. So I started in 2004, got my board certification, and by May of that year, I was ready to quit psychiatry and go looking for better tools. So it didn't take me too long.
And he did.
Yeah. Okay. Yeah. So in 2004, I quit psychiatry, and I decided that I was going to find some better tools. And one of the best things that happened to me was I ran into a former patient who I treated for about a year, and he was really representative of what was wrong with psychiatry for me. He was a guy in his 30s, he was an entrepreneur, he was very anxious, he couldn't work, he couldn't date, he couldn't drive, he couldn't fly, he was paralyzed with panic and anxiety. And I treated him with the usual techniques that I learned in my residency. I gave him cognitive therapy, SSRI, and benzodiazepine. And after about a year of treatment, he still wasn't better. So when I ran into him, he said, look, you know, after you left town, I went and got tested for celiac disease. I came back positive. I stopped eating gluten, and within a few months, my anxiety was gone. I stopped my medications, and still my anxiety was gone. I just talked to him a few weeks ago. It's now been more than 10 years since we had that first conversation, but I'm really grateful to him. He's doing great. What happened was he was able to go ahead and start his business. He could travel. He could do whatever he wanted. He started a family. So he was a huge instrument in putting me right on the path to looking for root causes in psychiatry. So I thank him. So I went out and looked for my lever, like Archimedes, looking for the long lever to move the earth. Next.
Oops.
Yeah, I'll click the slides for you.
Okay, thanks. So I had my own crisis a couple years after I finished my residency in 1993, and within a couple years, I started having this sawdust sickness, and I couldn't get the words out of my mouth when I was talking with my clients. And long story short is I figured out it was because I didn't believe the words that I was saying. And that was a crisis for me. Will got to quit. I didn't get to quit. Okay, I was up to my eyeballs in loans. I couldn't, I needed to make it work. So I was in crisis, and what I did was simultaneously, I signed up for the advanced psychotherapy training at the local analytic institute, and I hedged my bets by also apprenticing myself to my acupuncturist for a wonderful 3 years. And I thought that acupuncture would be just a screwdriver to go with my hammer or something like that. But it completely changed my worldview. It catalyzed a deep transformation inside of me. I changed my practice. I quit my psychoanalysis. I got a therapeutic divorce. And I was completely initiated into the world of integrative medicine, and the sawdust went away.
So I went on my journey looking for tools. I went to meditation, I went to shamanism, I went to the jungle in South America, I went to inflammation and dysbiosis education. I learned how to treat adrenal fatigue. I went to programs with Janet to learn about functional approaches. And as I developed this toolkit, I started to shift, like Janet did, my whole view about psychiatry. I wasn't just looking for tools to treat symptoms anymore. I was developing a different way of looking at what is going on for these folks that I was treating.
And then when I had a knock at the door about 10 years ago when perimenopause arrived at my house, and I thought I was just cruising along fine, practicing my holistic psychiatry, and then all of a sudden I had this stabbing pain. It was like one paring knife in each eye. If I would try to read for more than 10 minutes at night, it was completely unsustainable. So I saw all the doctors. None of the treatments worked. Finally, I found hormone replacement therapy. So, but I needed to know the science. I'm an engineer, I have an engineering background. I needed to know the science. I couldn't find anybody, so I thought, well, I'll just, so when Will and I went to the HRT training program in 2009, I was really just wanting to treat myself. I didn't think I would be treating anyone else. I didn't get quite enough, so I went back for another program, and all of a sudden found myself completing a 10-module functional medicine fellowship, and my transformation was complete. So we have been working together with our friend Scott Shannon in a study group for about 15 years, fine-tuning our approaches to integrative psychiatry, and we're so happy to present that to you tonight. Here's our model. People come in wanting help with their symptoms. They're in pain, so we meet them at the symptom management end of this model. And we don't, of course, buy into the party line that symptom clusters represent diseases. We know that symptom clusters are downstream effects of deeper root causes. Just like you see someone with irritable bowel syndrome, you don't think, oh, that's a disease. We see someone who comes in with insomnia and depressed mood and fatigue and brain fog. We're thinking, okay, they have a major depression phenotype, but they don't have that mythical disease called major depressive disorder. But as soon as we can jump out of symptom management up into the business end of this model, we want to work with them on physiologic and psychospiritual root causes. The thing that makes our model different from standard functional medicine is that we spend equal time addressing these two categories of root causes, and that makes all the difference in terms of outcomes. We have learned and we acknowledge the central role of trauma in changing the nervous system and in a downstream way affecting every organ system in the body. So if we don't include the treatment of trauma and psychospiritual root causes, the outcomes aren't nearly as good.
Right. So we start with the symptom management, and we really make an effort to not over-medicate people, because we don't want to numb people out to where they lose motivation and they lose steam in their personal journey of their soul's mission in this planet. So we're aiming for the window of tolerability, and we're building rapport with people. We're buying time so that we can actually look at root causes and we can treat those. It's important to look at the healer's capacity for tolerating intensity. So Janet and I have both been through, the journey we shared with you professionally, but we've also had a personal journey with our own intensities and our own challenges. And I think the way that you as a healer approach your own challenges in your life is really going to determine how much space you have in your heart for the intensity of the people who work with you. So let's look at some definitions of normal. So I think, in this culture, in a materialistic culture, we tend to think that everyone's having a normal experience, but we aren't. And our experience is probably worse than their experience, right? So, and this is reinforced by advertising, especially direct advertising of antidepressants. So it's important in the treatment of psychiatry from a functional perspective, I think, to have conversations with patients about what's realistic. Life is challenging, life is difficult. There are joys and there are wonders of life too, but not everyone's having a Pepsi commercial ad inside of their lifetime,
So conventional medicine and integrative medicine, everyone agrees that if we can't engage people in change behaviors, then the rest of everything that we're doing is a moot point, right? So this is our attempt to help you figure out where people are stuck. In integrative healthcare, we're all midwives of transformation. And people get stuck in the birth canal of transformation. And this is our attempt to help you figure out where people are getting stuck. So basically, this is a river running from the bottom to the top, a river that takes people into their growth process and their evolution and their transformation. And people can get stuck in a variety of places. When people get stuck over here on the right-hand side, they have too many symptoms. They're overwhelmed. They're hunkered down, and you can see that arrow going down to the bottom. They may be dissociated. They're shut down. These are people who need help with symptom reduction. Whether you use meds, you use supplements, you use mind-body tools, whether you use psychotherapy, you have to help these people to have fewer symptoms so that they can find the sweet spot here in the middle on the x-axis where they can get engaged in their transformational process. The people, when they're stuck on the left, and there's no judgment here, we've all been stuck in all of these places. When we're stuck here on the left, people are over-medicated. They're too comfortable. They're complacent. They're passive. And that might be because of psychiatric medications, but think of anything that people binge on, and that will do fine. You know, people can be over-medicated on their TV or their food or their exercise or their work or whatever. These are people who need more access to their feelings. So they might need some weaning, they might need some help coming down from their favorite numbing substances so that they can get to the sweet spot in the middle where they're engaged with their transformational process. And when people are stuck in the bottom here, in the not yet willing place, they need stories, they need role models, they need paradigms. That's why in my practice, I consider it part of informed consent to explain this paradigm to people. People will make different choices. People will make different choices about their medications or about their treatment plan if they understand that their symptoms have meaning and that the symptoms are part of a journey. Just like my journey with the sawdust feeling. It took me to a place that I needed to go and moves people into engagement and transformation. It's such a helpful story to tell people, and it's so different from what they hear on the TV ads for the antidepressants, you know, where it looks fun and easy and clean, and it's available for a low copay. You know, and then they list that list of side effects at the end in a fast voice, you know, all those hilarious side effects at the end. But what the side effect that we worry about that they don't say in those ads is that pharmaceutical numbing may cause you to put your own precious life journey on pause.
Right, so we don't want to help contribute to that. So on this x-axis, challenge and support, we want to emphasize that we consider love to be defined as the combination of support and challenge. Okay, and that's a little bit different from the cultural message people are getting, where if you love somebody, you support them all the time and you never challenge them. And we also believe that the maximum growth happens at the border between challenge and support. So that's this middle ground here of moving people down, helping people move down the river into engagement and transformation. We can't develop resiliency without challenge. Challenge is necessary. So we don't want to take that away. We want to add whatever's needed to keep people moving. Okay, so here's a smattering of symptom management tools that we teach at the Psychiatry Masterclass. We tend to go for the least toxic symptom management tools, and we try not to use medications long-term or at high doses. You know, symptom management could include short-term doses of pharmaceuticals at lower doses. It could also include mind-body techniques, which are not listed here.
So there's an epidemic of inflammation and an epidemic of sympathetic overdrive. We have a lot of activation symptoms that we deal with people, so we're using things off of this list, things that support GABA levels and things that inhibit, that lower glutamate levels in the brain to help people with their overactivation. And we prescribe autonomic nervous system treatments the same as medications. These are very powerful tools that help people to reduce their symptoms. Conventional medicine fails us by prescribing a pill for every ill. If we just prescribe a supplement, even a supplement or a mind-body technique for every ill, that's not substantially different. So it's very important. That takes us to the next important arm of the model, which is the physiologic root causes. Now, all of you in the audience who practice functional medicine and at home know this list very well, and this is the same list of root causes that we assess and treat in our psychiatric patients. I think of this like a video game where if you get your physiology optimized, you can unlock deeper levels of the game. We can't predict what journeys people are going to take if they get their physiology optimized, but we can tell you which journeys they're not going to take if their physiology is out of whack.
So as we get into talking a little more about trauma, we want to start off with some definitions. For our purposes, trauma is not an event. Trauma is a persistent pattern of dysregulation in the body. It's a pattern of dysregulation in the hypothalamic pituitary axis, it's dysregulation in the central nervous system, and dysregulation in the autonomic nervous system. I want to point out for the functional medicine people in the crowd that this bottom study here, C-reactive protein, which is a general marker of inflammation in the body, elevated after 20 years of childhood maltreatment. So,
stays elevated for 20 years after childhood maltreatment. Yeah.
Yes, for 20 years. So this part of our talk is beginning to close the gap between functional medicine and the new psychiatry, illustrating the point that long-term trauma in the body is mediated by inflammation and autonomic overdrive. Okay, so if you're treating diseases of inflammation in adults, you're probably treating people with trauma. That's one of the take-homes we want you to have tonight. Now, speaking of childhood trauma, I want to tell you about what we think is one of the most important studies that's ever been done in medicine was the ACE study, so the Adverse Childhood Events Study. This was led by Vincent Folletti at Kaiser in the 1990s. How many people have heard of the ACE study? Does anybody know about it? Okay, great. So those of you who don't know about it, amazing results. So he took a 10-item questionnaire that takes about 3 minutes to administer. And the items on the questionnaire include all kinds of different adversity, from divorce to substance abuse to incarceration to violence in the home to abuse. And he tabulated the results, and what he got was about 2/3 of Americans have at least one ACE in their history. So this doesn't start, so the picture of what's normal starts to change if you look at it that way. And if you have 2 or more ACEs in your history, then you've got an 100% increased risk of autoimmune disease. So trauma is involved in causation of the diseases we're trying to treat in medicine. Now at the top, we have an interesting study of Marines where they tested inflammation in these guys before they went to combat, and then they checked to see who got PTSD in combat. And the people who were inflamed before going to combat were the most likely to get PTSD during their deployment. So inflammation and trauma is a two-way street. Inflammation predisposes to trauma, and trauma causes inflammation.
And we encourage you to do a deep dive and look under the hood for your own trauma. You don't know what's under there until you look, and you certainly don't know what's under there for your patients until you look. We teach this professionally, but we've also learned this material personally, dealing with our own high ACE scores. And physician lifespans are 20 years shorter than the American average. So if you're anything like us, you'll be more effective, live longer, and more fulfilled as a provider if you deal with your own ACEs.
Right, which reminds me of another study that showed that if you have 6 or more ACEs, your lifespan is reduced by 20 years. So 20-year reduction for doctors, 20-year for 6 ACEs? Okay, so this study also showed an interesting connection between long-term inflammation and childhood abuse, a different angle on it. McGowan took brain samples, post-mortem brain sampling from suicide completers, and what he found was that the density of cortisol receptors in the hippocampus, I'll walk you through this, was reduced in people who had had childhood abuse. So lifelong, all the way through to their death by suicide, they had less cortisol receptors in the hippocampus. The reason that's important is because those receptors are necessary to complete the negative feedback loop. So these folks with early childhood trauma were not able to get their cortisol levels down adequately because there was a reduced density of receptors, which comes from methylation of this gene, NR3C1. So again, making the point that we need to treat not just the physiologic causes, but also the psychospiritual causes of medical disease.
And that brings us to the third arm of our model, which is addressing psychospiritual root causes. Remember that trauma is not an event, it's not a memory, but it's a pattern in the nervous system, and it's a pattern that changes the nervous system and trickles down to every organ system in the body. We disagree with the narrow definition of trauma that's espoused in the DSM, which includes helplessness, events facing helplessness in the face of life-threatening events. We think that the definition of trauma should be broadened to include what we call little t trauma, commonly called little t trauma, which is relational trauma. It has to do with rejections and abandonments and humiliations. It has to do with not being seen and known, which are two fundamental human needs that follow closely behind food and water. Insecure attachment style is an important adaptation to relational trauma, and I'll talk about that again in a moment.
And I'd like to share a quick story of post-traumatic growth. I had the good fortune to be a part of a research team studying MDMA psychotherapy for chronic treatment-resistant PTSD. And one of the participants in our study gave me permission to share this. As he was beginning to transcend and include his trauma from deployment in the military, he received a kind of an image in his mind during an MDMA session where he, that we were doing MDMA psychotherapy with him, where the image was of a beautifully carved piece of wood into the shape of a man. And he came to realize that this is how life works, is that you start off as a kind of a rough piece of wood or like a stump, and then you become carved by your experience of life. And he didn't regret that he had been to combat. He didn't regret anything that happened there. He was able to appreciate the wisdom and the deepening and the strength that he gained from everything he faced. So when people start to see the balance of the downsides with the benefits of the adversity that they face, you know that they're moving in the right direction.
And they're remodeling their brains.
Right.
So we all have an enduring attachment style, and it's either a secure attachment style or it's an insecure attachment style. And you develop an insecure attachment style as an adaptation to trauma in your earliest childhood caregiver relationships. People who have an insecure attachment style, and there are two examples of types, insecure attachment types listed here, those people can't tolerate the intimacy, the vulnerability, the collaboration, the dependency that's needed to have a successful healthcare relationship. So this is important in every healthcare relationship. It's a major obstacle to health and healing. Attachment style is like an unconscious computer program that's running in the background, controlling all of your relationships and controlling all of your beliefs about what's possible in life. And this is ridiculously prevalent. In one study, 88% of people with primary hypertension had insecure attachment styles. And if you look at chronic disease outcomes, those with insecure attachment styles had worse outcomes than those with secure attachment styles. So these are people in your practices. They may be sitting across from you smiling and nodding. They might not be smiling and nodding, but they might be smiling and nodding, but you can't get any traction with your treatment. This is something to be aware of and diagnose, because this is a major obstacle to good outcomes in all integrative medical care and all conventional medical care. It's one way that trauma reduces health, overall health, and reduces longevity. So this is the reason why we recommend that you become familiar with some specific psychotherapy treatments with trauma. And when you're building your team or you're building your referral network, that you include referrals for trauma so that people can change their brains. This is not a death sentence when people have their reduced density of cortisol receptors in the brain. It's something that can be changed with treatment. And this is a sample of treatments that we've found to be effective.
Exactly. And so insecure attachment patterns can, as Dan Siegel says, be reversed, and you can earn secure attachment, is the term that he used. So attachment patterns are learned behaviors, and they can be changed. That's the good news.
It's not personality. That's one of the take-home messages, is the style that people have when they're so defensive, or they're non-compliant, or they're resistant. You know, that's not personality. That's a learned adaptation to trauma. And we are wholeheartedly in favor of the movement toward integrative coaching. People need education. People need accountability. There's a huge value in that. But this is an entirely different animal that needs to be added on. If people have a trauma background, they need a psychotherapy that's specifically directed toward their trauma.
So I'd like to share with you some pooled phase 2 data from the MDMA psychotherapy trials for chronic treatment-resistant PTSD. Does everybody know what MDMA is? Has anybody heard of that? Okay. So MDMA is a chemical that causes a heart-opening experience, decreases interpersonal fear, allows people to get in touch with trauma with much less defensiveness and fear. So this data is from end of phase 2 meeting with FDA. And I just want to walk you through this. On the y-axis here, we have global CAPS. Mean the CAPS is the clinician-administered PTSD scale. It's a scale that goes from 0 to 136. The people in phase 2 in these studies is an N of 107. Started in the mid-80s, which is rather severe PTSD. And 50 is the cutoff for the diagnosis of PTSD. So at 12-month follow-up, the average was in the 30s. And people tended to improve as they went along toward the 12-month follow-up.
And these kind of results are unheard of, by the way.
Yeah, this is a difficult condition to treat. There's a tremendous suffering and decades of symptoms for some people. So how does MDMA psychotherapy compare to Paxil and Zoloft, the FDA-approved medications? You can see here that, first of all, when you subtract out the placebo group, with Zoloft you have a 6-point drop in the CAPS scale. On a scale of 136, a drop of 6 is not that much. And then 10 points for Paxil, and with MDMA, 26. And then look at these dropout rates, and these are typical for SSRI research, 30 to 40% dropout rates because of side effects, and then you have a 7% dropout rate with MDMA. So this approach is now in phase 3 clinical trials, and it's probably going to be a few more years before we see this up for approval with the FDA for general use. I've got 2 clickers in my pocket, so there's one of them's working. There we go.
So that brings us back to the model. Conventional medicine and even functional medicine to some extent says that the Earth is flat, and this is a 2-dimensional model. But we're here to tell you that the Earth is round, and this is a 3-dimensional model. What I mean by that is that there is no separation between physiologic root causes and psychospiritual root causes. Each one is both a cause and an effect of the other. If you have psychospiritual trauma, which is nearly ubiquitous, it will disrupt your physiology. And if your physiology is not optimized, it will block your psychospiritual journey. So this is not a stick figure anymore. It's a chalice. It's a 3D chalice of health.
Nice. And this is a more detailed version of the 3-arm model. The point I want to make here is sharing, this is a tool that we use to teach the Psychiatry Masterclass. As James was saying, we need to go upstream. We need to look at the upstream effects. So in psychiatry, we look at all these inputs into psychiatric health, filtered down through personal history and traumas and epigenetic changes into these functional medicine pathways, unconscious beliefs. And down here, we have the outputs. So coping strategies and symptoms are simply outputs of dysregulation anywhere on the map. So any symptom can come from anywhere on the map, but we're going to look for root causes because we're not just going to medicate symptoms, which is what we were taught to do in our training down here.
And that conventional psychiatry uses that whack-a-mole approach with just the symptoms at the bottom, labels and whack-a-mole, and loses the whole upstream activity.
Exactly.
Yeah. Our 10-year vision is medicine and psychiatry united together with a common vision that puts trauma and stress at the core of all levels of human health.
So let's do this, people. Is anybody up for this? Okay. All right. Thank you.
So one way to jump in is to find yourself on this model. Find yourself personally, find yourself professionally. Where are you stuck? And for that matter, take all of us as a community and put us on this model. Where are we stuck in the birth canal of transforming medicine for the future? Most individual practitioners are stuck over here on the right. They're overwhelmed, they're overworked, they have their heads down, they can't figure out when or how they're ever going to change their practices. And our message is that community is the antidote. The way to move out of the yellow on the right and up into the green is community. We've benefited so much from the community that we've had with other psychiatrists in our holistic psychiatry study group and with each other, with Scott, Shannon, and Will and I and others. And that's part of why we decided to come and present to you together as a community.
Mm-hmm. Yeah, and we're really grateful, James, to be a part of this new community. Thank you.
Yes.
So if you'd like to learn more, if you'd like to hear about our programs, this is where you can find us. Psychiatry Masterclass is where psychiatrists come to learn functional medicine and where functional medicine doctors come to learn psychiatry. Thank you.
Thank you.